Loud. Hey, hello everyone. Nice to see so many of you guys. Welcome to one of the first CP Solvers intern bootcamp sessions. We're really excited to try out this new series. And I probably know most of you guys, but for those of you who I don't know, I'm Maddie, and I'm one of the four people who's helped putting this first session together alongside Yusuf and Sarah and Mark. And just kind of a quick intro about kind of the vision behind this series. So we thought to put on an intern bootcamp session because many people within the CP Solvers community are starting residency in a few short months, and we thought it would be helpful to put on these sessions to just go over some of the bread and butter topics in internal medicine and practice our thinking and reasoning on these topics so that we feel more comfortable when residency starts. And just to preface that this session is very casual and interactive, and no one should feel stressed about saying the wrong thing. We're all here to learn, and we're going to do a lot of breakout sessions and discussions. So very casual. Please share your thoughts, and it'll be very fun. So I'm going to pass the mic to maybe Yusuf, who can then pass the mic to Sarah and Mark. And Yusuf, you can introduce yourself and maybe share what it was like for you to experience a hypotension rapid response, given that that's the topic of the session today.
Yeah, hi everyone. I'm Yusuf. I'm one of the PGY3s at Emory. I'm also a CP Solvers member. Very, very excited for today. So when I was an intern and at the end of intern year, I was like, oh, I wish I could create a boot camp for interns. And this came to fruition through Maddie and Sarah's efforts in creating this endeavor. And I'm very, very excited. The first few times we were called to a rapid response that had hypotension, I believe I needed a rapid response because I wasn't sure how to run this through. But having a framework was very, very helpful, and rotating through the ICU and seeing the extreme spectrum of respiratory disease, hypotension made me much more comfortable evaluating patients. But what I learned is that the more you go through cases, the more you get comfortable. And hopefully this will be one way to practice and first of many in the future. I'll be presenting one of the patients I had today. I'll pass the mic to Mark.
Hey everyone, my name is Mark. I'm one of the third-year residents at Penn, also one of the Academy members. But I totally agree, Yusuf. I think rapid responses in the beginning of residency, especially intern year, are very anxiety-provoking. But my senior residents always told me like never to worry alone, right? You can always ask for help and lean on your, this VMR community, and then also your residents when you're in that situation. But like Yusuf said, having a organized approach to common rapid response situations. Today we'll talk about hypotension, but tachycardia, hypoxemia, having those algorithms in the back of your mind and just taking a deep breath, I think just goes a long way. So really excited to chat.
And hi everyone, my name is Sarah. I'm a fourth year medical student at UCSF, also part of the CP Solvers Academy. Really looking forward to learning with everyone today because I'm also preparing for my intern year and hypotension gets my heart pounding too. So looking forward to the session with you all.
Amazing. So just to clarify the format for everyone here, so we're gonna give the case in aliquots, and then we're gonna do some breakout sessions where you guys can talk amongst yourselves about what's going through your mind with some questions we have, and then we'll come back together and do some teaching on that. So let's get started. Yusuf, do you want to share the first part of the case we have?
Yeah, absolutely. I see everyone is making hypotension puns already, so that's great. So you're on night float. You're on a cross cover shift, which means you're working overnight and you're basically covering a list of patients, and you're the first responder to anything that happens overnight. And you get a call from the nurse, and you talk to the nurse, and they say that your patient is hypotensive, and that their blood pressure is 85/35. Before we go further, we're gonna create a breakout room for the first question, which is before walking the patient's room and as you're walking there, what is your approach to hypotension? What are you planning to check on history? vitals and exam? And how can you get the most out of the support staff? So to repeat those, like what approach or framework are you thinking of? What is your plan to get on history, vitals, and exam? And how can you get the most out of the situation? I'll be creating the first breakout room. We can discuss for a few minutes and then we can circle back.
Okay. Great. Thank you. All right. Well, welcome back, everyone. The breakout rooms still have 15 seconds, so people are going to trickle in. So for this next part, once everyone comes back, we're going to first talk about, we're going to call in a few people to hear what you all talked about in your group in terms of what framework you think of for hypotension. So I'm going to just call on some people to ask if they feel comfortable sharing what they talked about in their group. If you don't feel comfortable, no problem, but just to reiterate, this is a totally casual, safe space just to share thoughts. So I'm going to call on, maybe I can call on you, Abir, if you feel comfortable sharing. What did you talk about in your group in terms of a framework for hypotension?
Okay. Hey, hello everyone. Yes, for sure. About patients with hypotension, we make a small framework, a small approach, specifically for ICU patient. We categorize into, first of all, it could be distributive shock. It could be septic or non-septic. So we must ask if the patient is febrile, and in physical exam, we must take any clues that may help us about the extremities, and also we must keep in our mind some life-threatening condition like obstructive shock, like pulmonary embolism, and acute coronary syndrome, like inferior MI. Also, it could be hypovolemic shock, like local GI bleeding. So yeah, so we must keep this in our mind, and with physical exam and past medical history, we could find the final diagnosis, and also it could be from some medication that may cause allergy or anaphylactic shock. So yeah, this is some of our talking during the discussion.
Abir, that was brilliant. I think you're ready for intern year. But that was so wonderful and clear. And before we kind of summarize what you said, maybe I'll call on one more person to hear what they talked about. Jessica, I see your videos on. Do you mind sharing what you talked about in your breakout group? If you feel comfortable unmuting.
Okay. In our group, we talk about, first of all, like are many causes about can generate hypotension in a patient. First of all, we have to know what are the diagnoses because the patient is there. Like Abir told us, maybe could be an infection disease. We think about a septic etiology. If the patient is hospitalized for a trauma, for example, I think in other etiology, maybe an hypovolemic. If the maybe another causes could be pharmacology. The patient could be with antihypertensives. The physical exam, like the same that say Abir, maybe how is the consensus? I don't know how do you say that. I don't know.
Amazing thoughts, both Jessica and Abir. And just to kind of summarize what I'm hearing from you both. So one framework that you can use for hypotension is thinking of 4 buckets that are based on the mechanisms. And those 4 buckets, both Jessica and Abir touched on. So those are cardiogenic causes, hypovolemic causes, obstructive causes, and then distributive causes. And those are just, when you're walking into a hypotensive rapid response and there's so much on your mind, it's just kind of helpful to have those 4 buckets in your mind to refer to. And all of those, it's helpful to remember just those 4 buckets, but you can also kind of anchor it back into the equation for blood pressure, or MAP, also mean arterial blood pressure. If you recall, MAP is, I don't know if anyone wants to put it in the chat if they remember the equation for mean arterial pressure. I'll give people a few seconds if you want to think back to that. But does anyone want to call it out if you remember kind of what the equation is for mean arterial pressure? So exactly, yeah. So blood pressure, mean arterial pressure, is equal to cardiac output times systemic vascular resistance. So if you think of low blood pressure, hypotension, you're either going to have low cardiac output or low systemic vascular resistance. And so these 4 buckets are kind of anchored in that equation. So for example, if you have a cardiogenic etiology of hypotension, that will cause a low cardiac output and then subsequently causing hypotension. Or if you have low systemic vascular resistance, so for example, in a septic shock picture or in that distributive shock category, like anaphylaxis, that's another way that you can have it. So I think anchoring yourself in those 4 categories and kind of rooting it in that equation can be a really helpful framework to have when you're on your way to this rapid response. And then now maybe, Mark, if it's okay with you, maybe I'll pass the mic to you to share some pearls that you've had just kind of practically when you walk into the room, before looking at the vitals and the physical exam that Abir and Jessica commented on. What were some pearls that you wanted to share in terms of, staying at the head of the bed and things like that? Some like practical tips.
Yeah, no, great discussion so far, Maddie. And I just want to emphasize that equation is one of the most important equations in medicine. MAP equals cardiac output times SVR. You can really derive all causes of hypotension from that equation. But yeah, just really practical tips for me is that, like I said, first step when the nurse calls you is just take a deep breath, right? And, ask for help, get the rest of your team ready to, run an excellent organized rapid response. But typically, as soon as I walk in the room, the most important thing is obviously laying eyes on the patient, right? Taking a look at the patient. But if you're running the rapid response, it's very important to stand at the head of the bed and kind of identify yourself as the rapid response leader, right? You want everyone to know in the room that you're the leader and you're going to be the one assigning roles, right? There's a lot of roles in a rapid response, right? There's a leader. There's someone giving medications, right? There's someone digging into the chart. There's someone doing orders, right? So assigning roles is very important. And remember, vitals are vital, right? So as soon as I look at the patient, I know what the rapid response is for, and I've assigned roles. I'm also getting a fresh set of vitals, right? And then another really practical thing that I feel like as a medical student, I really think about, but as a resident, you start to think about access, right? Because most, especially for hypotension, we need really good peripheral IVs, right? So we can give a bunch of medications. We'll talk about the management of hypotension a little bit later, but you want good access to give fluids, to give antibiotics, to give blood. And I usually always ask for a minimum of 2 IVs. And preferably, I would like these IVs to be large bore. And what I mean by large bore is that the gauge of the IV has to be large, right? So a big radius, right? So the flow rates are high. So kind of in summary, I walk in the room, I assign myself as the rapid response leader. I ask for a fresh set of vitals. I make sure the patient has really good access, and then I assign roles. And then we'll kind of talk about the rest. But that's kind of your rapid response checklist before you start actually running the rapid response.
That's great, Mark. Thank you. Let me give you some more information. So as you're headed to the room, you open the chart on your phone and you start reading about the patient. It's a 60-year-old male. They have a history of coronary artery disease, HFrEF with an EF of 30%. They were admitted for acute kidney injury earlier that day. You enter the room and on a quick review of vitals and labs, the temperature was 101.6, which is elevated. The blood pressure is 85/35. The heart rate is 103. And the respiratory rate is 18. Their oxygen saturation is 95% on 2 liters of nasal cannula. Of note, the labs were notable for a white count that is elevated at 18 and a creatinine of 1.5 from a baseline of 0.8. So before I hand over the mic to you all and create the breakout rooms, the first question is the patient in shock? How can you differentiate between septic and cardiogenic shock? And what are the different markers for septic versus cardiogenic, if you can think of those? And what are you looking for as you're brainstorming here? So I'm gonna create the breakout rooms once again.
Hello, everyone. Welcome back. I hope you guys all had a really nice discussion. Maybe we'll just also, have two participants kind of talk about what you guys chat about. Maybe Noah, maybe I'll call on you. What did you and your group talk about for this next kind of aliquot? Okay. And no worries, Noah, no worries. Hui Ting, how about you? What did you guys talk about?
Yeah, so we talk about like what we see the physical exam when we see a patient between to differentiate between cardiogenic shock and this septic shock, which is within the bucket of the dysregulated shock. So in the cardiogenic shock, we usually see the patient, the skin will be like cold, clammy, because there's a poor capillary refill. We see increase of elevated GVP, which is we don't see in the septic shock. If we compare a patient with septic shock, we usually see the skin, for example, it's warm. So also it's like more flush, and the patient usually have signs of infection, a febrile. So of course, we have to correlate that with the lab finding as well, with imaging. So yeah, that is a little bit what we talk about in our group.
That's perfect. Yeah, you guys are kind of using your physical exam, using the extremity exam, using the JVP, and then the patient's history to kind of differentiate this different etiologies of hypotension. I love that. How about you, Tansu? What did you guys chat about?
We also talked about similar things, and we looked at first patient's vitals, the heart rate being high, and the patient's respiratory rate, actually it's normal, and the white blood cell count being 18,000, patient having a sign of end organ damage with creatinine increasing from a baseline of 0.8 to 1.5. That all of that kind of put us more into like thinking about septic shock than cardiogenic shock. Yeah, and we talked about I think Jessica told us lactate being more than 2 and lack of crystalloid response would show us that the patient is in shock. That's in the first place how we decide that the patient is in shock. Yeah, so these are the things that we talk about.
Absolutely. Yeah, you guys kind of got into your perfusion markers, which we'll talk about. So that's great. Yeah, I totally agree. I think the vital signs, again, are so vital, and you can glean so much even about the etiology of shock from the vitals. So honestly, as soon as I look at the vital signs, one of the first things I look at is the pulse pressure. Now, how can you guys use the pulse pressure to differentiate different etiologies of shock? Have you guys heard of this before?
Can I say?
Yeah, absolutely.
Okay.
Please.
As I remember, in septic shock, we have a distributive shock. So we have low vascular systemic vascular resistance. So when we compare systolic blood pressure to diastolic blood pressure, we have a wide pulse pressure. In case of heart failure or let's say cardiogenic shock, we have a low cardiac output, so systemic vascular resistance will be elevated to compensate this, let's say, decrease in cardiac output. So both of systolic blood pressure and diastolic blood pressure will be elevated. So I guess that we will have a narrow pulse pressure when we compare it to the septic shock. So yeah,
Spot
I
on.
hope that will be correct.
Absolutely spot on. And the reason that is because remember, your pulse pressure is your systolic blood pressure minus your diastolic blood pressure. So a normal pulse pressure, let's think of our classic normal blood pressure, 120/80, right? So a normal pulse pressure is 40, right? And how I think about is pulse pressure, right? The systolic blood pressure, what really determines the systolic blood pressure is the stroke volume, right? So your pulse pressure is proportional to your stroke volume. And then what makes up the diastolic blood pressure? The systemic vascular resistance, right? So your pulse pressure is inversely proportional to your systemic vascular resistance. So essentially, if your stroke volume goes down, your pulse pressure goes down, right? If your systemic vascular resistance goes down, like in distributive shock, your pulse pressure is going to widen, right? So the pulse pressure you can get a lot, right? Low pulse pressure, going to think cardiogenic. High pulse pressure, going to think distributive. So first look at your vital signs, right? And then a fun mnemonic that I learned during residency for bedside assessment of perfusion status is this mnemonic, ride the bus. And it's focused on B, U, and S, right? So first, B stands for brain, right? So how is our brain being perfused, right? So I assess the patient's mental status. I ask them questions like, do you know your name? Do you know where you are? Do you know what year it is? So you can get a assessment if their brain is being perfused, right? And then I look at the urine output, right? Because if a patient is in shock, right, they should have decreased perfusion to their brain and their kidneys, right? So I'll look at if they have a Foley, I'll look in their Foley, or I'll ask their nurse, how has their urine output been over the last few hours, right? And then finally, the S part of that is the skin, right? The skin exam. And Viting, you were mentioning the skin exam, how if you touch the patient's extremities and you feel that they're very warm, that could be suggestive of a distributive picture, right? Because the skin is warm because you have a low SVR state, right? So warm skin usually means a low SVR state, which is signifies usually a distributive process. And kind of a practical tip is that a lot of patients' skin is pretty cold at their feet and their shins, to be honest, because that's usually exposed to the environment. Right now, when I'm talking, my feet are very cold, but I think I'm not in shock. I hope I'm not. So I always feel at the knees. I think that's the most practical place to feel for extremity perfusion. And then another thing is that, has anyone heard of capillary refill? Has anyone ever heard of that?
Yes, it's a pretty simple exam that you can include in like a cardiovascular assessment where you press on the patient's fingernail and the color should return in less than 3 seconds.
Absolutely. That's perfect, Arian. And there's actually a study looking at it. There's a JAMA study. I believe it was in 2016. It was the Andromeda shock trial, which essentially used capillary refill versus lactate as a resuscitative measure. And there wasn't a significant difference, but there was a signal to actually a mortality benefit of using capillary refill as an assessment of perfusion over lactate. So I think really practically, honestly, I use it all the time in the hospital. But I think the most important thing when you're doing this ride the bus, assessing the mental status, assessing the urine output, and assessing the skin, is that anytime you do an intervention, you then ride the bus again and assess your response, right? You should expect your mental status to get better, your urine output to pick up, your capillary refill to decrease if you do an intervention and to try to increase perfusion. And then lastly, I'll just kind of give a shout out for point of care ultrasound for you that have that at your institutions. It could be a really nice tool to rule out some things in a rapid response, right? Usually during every rapid response for hypotension, I'll always look to see if there's any evidence of tamponade. I'm not the best ultrasonographer, but it is not, it's not too difficult to, in a parasternal long view to see if someone has a big pericardial effusion. And the same thing to see if someone has a lot of right heart strain to suggest like a pulmonary embolism as a sign of obstructive shock. I think the IVC exam, the inferior vena cava exam, has its limitations, and studies are kind of mixed about it. So I won't talk about that too much, but you can also kind of use that as well. Okay, let's turn gears a little bit. Next, let's talk about sepsis. So we talk about sepsis a lot. Can anyone tell me, like, what is sepsis? Either in the chat or you can unmute. One of the most common things we deal with in the hospital. Is sepsis just an infection? Yasmin, perfect. Would you, if you're in a good place to unmute, would you mind just explaining a little more? That's perfect.
Of course, I really like sepsis. I mean, not in the patients, right? But as a topic, it's basically this dysregulated response to the infection. So it causes tissue and organ damage, and subsequently it evolutions to organ dysfunction. And that's when it can come with septic shock, like sepsis, and septic shock is not. That's why it's like confusing, but basically sepsis is the wrong response, dysregulated response, and the septic shock is like the symptomatology. I don't know if I explained that.
That is perfect. That is perfect. Exactly what you said. And you said in the chat, it's a dysregulated response, right? Someone that just has, dysuria and then pyuria on their UA, and then has a localized simple cystitis and no evidence of systemic inflammation, doesn't have sepsis. They just have a simple, uncomplicated cystitis, right? But this is a dysregulated host response to an infection leading to life-threatening organ dysfunction, exactly as Yasmin mentioned. And does anyone know the definition of sepsis? The technical definition? It changes often, but does anyone know what the definition of sepsis is? You're on a roll, Yasmin.
Can I say it out loud?
Yeah, absolutely.
2 plus, I think that's the last time I checked, 2 or more serious criteria, which is the temperature higher than 38 or lower than 36. I'm still learning Fahrenheit. Heart rate more than 90, or respiratory rate more than 20, and I forgot the fourth one, and the white blood cell more than 12 or 13, if I'm not wrong. So basically, if you have more than 2 of those criteria, or 2 plus a confirmed suspicion of infection.
Perfect. Yeah, and I'll just say quickly that there was a definition in 2016 that used QSOFA, but that actually the new guidelines in 2021 went back to SIR. So it's exactly what you mentioned. And just for the sake of time, the last thing I'll just talk about is what are etiologies of sepsis? What are your guys' first pass when you're like evaluating someone at the bedside? You think they have sepsis? What are the questions you're gonna? What are the kind of etiologies that you guys are thinking? The most common etiologies. Breathing pneumonia, lungs, GU, skin, chest, yeah, urine, abscess, urine. Perfect, guys. You guys are getting them all. I'll just mention my quick 6 are lung, like you guys said, urinary, intra-abdominal, hepatobiliary, skin and soft tissue, and line infections, right? And then some sneaky ones can be an endovascular infection like endocarditis, a bone and joint infection, right? And then you just tailor your evaluation to those causes, right? So for a pneumonia, you'll get a chest X-ray, you order a sputum culture. And yeah, like I said, if you know the most common etiologies, then you just evaluate for those. And the last thing I'll say, there are some sepsis mimics, right? So anytime you think someone has sepsis and maybe you don't identify a source of infection, think of other causes of distributed shock that aren't sepsis, like adrenal insufficiency, pancreatitis, anaphylaxis, cirrhosis, neurogenic shock.
Thanks,
Cool.
Mark, for going through a great framework for sepsis and initial markers of perfusion that are really important in the assessment of anyone who has hypotension. I'd love to switch gears for a second to talk about cardiogenic shock. It sounds like based on the pulse pressure of this patient's case, we're thinking less like that, but I still want to make sure that given that this patient has a history of heart failure, can we think about the markers of cardiogenic shock and why this patient may not fit that mold. So I love to think about this by grounding myself in the definition and hemodynamic criteria of cardiogenic shock. And so as already mentioned, shock is hypotension and organ hypoperfusion, which Mark went into for markers of. But the hemodynamic criteria make cardiogenic shock unique, as well as the presence of a primary cardiac cause for the hypotension. So Ashutosh already mentioned in the chat that low cardiac index, which is cardiac output divided by body surface area, can be a marker of cardiogenic shock. There's another marker, hemodynamic marker, that we think about when we are categorizing people into cardiogenic shock. Does anyone know what that is? It's something that we measure with like a PA catheter, pulmonary capillary wedge pressure. Great. Can you speak about that, Yasmin? Oh, sorry, you're sharing a lot of pearls today. So
No, like actually, I have to stand corrected because I had said that the only type of shock that high SVR was cardiogenic, and that's super wrong. I meant that the PCWP was high in cardiogenic shock. It's the only one that has it in like higher. And basically it tells us the pressure like in the left atrial, like pulmonary area, everything that can cause issues in the left side can elevate the PCWP. But again, I really have a lot of trouble with that one. I might even say that I don't even know if that is right, what I just said.
no, that's exactly correct. The pulmonary capillary wedge pressure is an estimation of left ventricular end diastolic pressure. And it is a marker of congestion because of the heart's inability to pump blood forward. So you had a lot of wisdom there with what you said. So again, cardiogenic shock is low cardiac output and elevated pulmonary capillary wedge pressure, which indicates poor inability to perfuse the body and also congestion as a result of it. And so in addition to the markers of perfusion that Mark had mentioned, can anyone share in the chat or verbally what other things about perfusion or congestion or volume overload that you would be looking for in a patient you're concerned for cardiogenic shock for? JVP. Parnam, would you mind, are you in a place to unmute yourself to talk more about JVP and maybe other markers of physical exam?
Yeah, absolutely. I mean, a JVP could give us like a good overview of the volume status for sure. So for instance, if a patient is in a distributive shock, we expect the JVP to be lower compared to a patient who is in a cardiogenic shock, higher JVP. And as already mentioned, the urine output is another marker that we may be looking for. And what else? I mean, perfusion in extremities, whether or not they're cold or warm, and yeah, basically that's it.
Great. Yeah, those are all great physical exam maneuvers. I think what I'd add to that is simply looking at the patient. Are they sitting up or lying flat? Are they on oxygen? Is there signs that they're tachypnic? Do they have signs that they have fluid in their lungs or fluid elsewhere in their body, like in the lower extremities or in dependent areas? Are there signs that they're not pumping blood forward? And I'd also mention that history can also be super helpful in determining whether or not someone has a cardiac cause, including things like paroxysmal nocturnal dyspnea, things like bendopnea, history of diuretic use or noncompliance. And total body weight, being up or down, are things that can tell us whether or not someone has a cardiac cause. Presence of B lines on POCUS as well. And then finally, I would say looking at an underlying cause for the cardiogenic shock, since it has to have a primary cardiac underlying cause. So what are the things that you would be looking for? Maybe someone can type in the chat. What are the other tests that you would measure to look for underlying causes? EKG troponin to look for ischemic causes. Great, Abir. And then there's another big imaging test that I'm looking for. TEE, yes, echo or POCUS, exactly. And so the last pearl that I want to share is, although there are all these tests and all this physical exam that can take a little bit of time in the emergency department to get, sometimes it's people come in early cardiogenic shock, and it's hard to determine, it's hard to differentiate between cardiogenic and septic shock if they're early, especially in younger people who have more reserve. So what are the exams that you want to find in people with maybe undifferentiated cardiogenic versus septic shock? And Mark had already mentioned one of these before, but I wanted to highlight it again. Cap refill is one. The pulse pressure, yeah, Hui-Ting, exactly. The pulse pressure is the first very quick data point that you can use to determine cardiogenic versus septic shock, as Tansu already highlighted in the discussion before. So now I think we have some tools to look at septic versus cardiogenic shock. Yusuf, I'll turn it back to you to share another aliquot about the case.
Thank you, Sarah. So on exam, the patient was awake and oriented ×2. They were on cardiac exam. They had a normal S1, S2, and the JV, jugular venous flow was not distended. On pulmonary exam, they had decreased breath sound in the left lower lobe. The abdomen was soft and non-tender. The extremities were warm to touch. On point of care ultrasound, the IVC was less than 2 centimeters and collapsible. And on lung POCUS, we saw V lines only in the left lower lobe, and there were no cardiac or pleural effusions. So the next and final breakout room, the question is, what is your initial management plan for this patient? And what do you think about giving this patient fluids, given that they have congestive heart failure? To be more specific, I want to know how much fluids, which type of fluids. I want to know if you're going to give antibiotics, which antibiotics, and if there's anything else you would do. So I want you to be as specific as possible. I'm going to fade the breakout rooms now. Welcome back, everyone. So I want a volunteer to tell me what you all decided on, assuming you are taking care of your patient and you're writing your notes, you're coming up with a plan. What have you decided for the fluids? How much? Which antibiotics? And so any volunteers?
I feel very confident on our group, so I'm gonna be the tribute here. So in our group, we were with Jazz and Yuki and Mariana, and we thought that because of the symptoms of the patient, we were probably dealing with a septic shock. You know, it was very localized. We're in the lung, the crackles were, so we can have a foci there, and we didn't have the JBP. We had also wide pulse pressure that can also be seen in septic shock. I don't remember more things because the whiteboard is not on. But I do remember that this patient had a history of cardiac failure. So I think that just calls for you to be more careful about how much fluids you're gonna get. And I remember learning about just dividing this patient in wet and dry, and then cold and warm. And that's just gonna guide you a lot to see if the patient actually needs fluids or if you're gonna need the resuscitation with other vasogenic agents. Thank you for putting the whiteboard. Also the IVC was low. The B lines were like just in that side of the lung. And I think that to end this, Jasmine suggested a coverage with an aminoglycosid, I think, and the Piptasa, because we don't know about Pseudomonas here, and then Vanco. Oh, Levo, sorry. Levofloxacin, I'm assuming to cover gram negatives, vancomycin, gram positives, and staph. And then the Piptasa, just thinking about Pseudomonas.
Thank you so much, Jimena. That's very, very impressive. Anybody want to volunteer to tell us which fluid and how much fluids you want to give in addition to antibiotics? We have a vote for normal saline. Okay, Javier with the normal saline 30 cc's per kg. So the Surviving Sepsis Campaign is a committee that meets every few years. It's formed by critical care physicians, and they come up with criteria and recommendations every few years, and they updated it. The most recent update was in 2021. So this campaign recommends 30 cc's per kilogram of fluids within 3 hours of identifying sepsis. And this has been protocolized across multiple hospitals. And there's a checklist now, a rapid response checklist of how quickly you're giving fluids after sepsis was identified. The quality of evidence is low, and it was a weak recommendation. This is based on a retrospective study that showed that patients that did not receive 30 cc's per kg actually had a higher mortality. And that's a big deal because not a lot of things help with mortality. In terms of deciding which fluid, in general, they recommend a balanced crystalloid, which is lactated ringer or normal saline. The difference in between normal saline and LR is not one of mortality. It's one of electrolytes and how normal saline can cause a normal anion gap metabolic acidosis. And we can go on this for hours. And there's a very good Core IM episode on fluids, especially Mark, who gets excited if I talk too much about LR normal saline. But in general, I tend to favor LR because normal saline causes this acidosis. And a lot of times what we didn't mention today is that states of shock can cause lactic acidosis, and you don't want to compound that. So in general, my first choice and almost always will be LR. And I almost forget the last time I ordered normal saline. I usually use normal saline in alkalosis or in traumatic brain injury, for example. In terms of antibiotics, there's no specific antibiotic that's recommended, but in general, you want to cover gram positives and gram negatives, and you want to be broad initially and then de-escalate after you find a source. Vancomycin was chosen by Jimena. That's a very good choice. The ACORN trial came out this year, which was a randomized controlled trial, which randomized patients to vancomycin versus vancomycin. The median duration of antibiotics was 3 days, and it did not show a difference in acute kidney injury between groups. It did show a slightly increased encephalopathy in the cefepime group. The difference was only 3 hours, but it encourages you to use Zosyn or Piptazo, especially that it has additional coverage of anaerobes. In terms of the patient having CHF, this is something that is contentious, and there's a lot of people with very strong opinions about fluids CHF and how much fluids to give and when to give. And I think the reason for that is that the data is a little bit heterogeneous in terms of CHF, and there's no randomized controlled trial data strictly for congestive heart failure and fluids. But in general, there are multiple small studies that have shown that patients who received 30 cc's per kilogram had a better mortality and did not have increased intubation rate. In general, the limiting factor for giving fluids is pulmonary edema. And if a patient is not at risk of pulmonary edema, if at baseline they don't have significant volume overload, this data empowers me to go ahead and give fluids unless I'm worried that their volume overloaded significantly, in which case I might opt to use pressors. But otherwise, I would go ahead and give fluids and reassess. And I often give 30 cc's per kg because patients with CHF do develop sepsis and they have a higher mortality from sepsis. And sometimes septic shock causes cardiac dysfunction. So a lot of times they go hand in hand, and it leads to a higher mortality. When you're in the resuscitation phase of sepsis or shock, I'm generally wouldn't shy away from giving fluids in the initial phase, and then try to reassess frequently in terms of the amount of fluid given. That's all I had in terms of information. I'm going to give you the case and what happened to my patient. So the patient was started on Vanc and Peptazo, and we gave them 3 liters of LR. Re-evaluation 3 hours later showed resolution of the hypotension. And following the chart over the next few days, they seem to have done better, with diagnosis being a hospital-acquired pneumonia. That was all we had for today. Before we open the room for questions, I want to say I'm going to put a feedback form in the chat. Feel free to give us feedback on what we did well, what you want us to do better in the future, and any topics that you want us to cover in the future, because we're happy to organize these, and we're also excited to start this series. I know you all are as well. So I put the form in the chat. Feel free to suggest topics, give us any feedback. That's what we're here for. And I'm gonna pause the recording and open the floor for questions.
So yeah, I just want to take 1 minute to talk about lactate ringers versus normal saline, because I think if anytime there's like a signal in the literature for, one medicine causing maybe possibly harm over other, I think it's always important to ask why. And you guys are all very intellectually curious, so I think you guys are always asking why. But essentially, normal saline has 154 milliequivalents of sodium in it, right? And just remember, our body has on average, about 140 milliequivalents of sodium in it. And then lactated ringers has about 130 milliequivalents of sodium in it. So lactated ringers is a little more physiologic in terms of the sodium balance. And essentially what happens is when you give someone normal saline, that sodium load, that like 154 milliequivalents, goes to the macula densa, your sodium sensing cells. And the kidney's like, wow, I have a lot of volume in me. This is a lot of sodium, right? Because your body uses sodium as a surrogate for blood volume. So what happens is that your kidney does what's called tubuloglomerular feedback and causes vasoconstriction of the afferent arteriole and say, okay, put the brakes on, we have a lot of blood volume. So essentially it can induce like a mini AKI and a non-gap acidosis. So even though like there's some studies that do show harm, some studies that show no difference, there is a physiological basis for why it can cause an AKI. So I just wanted to highlight that.
Thank you so much, Mark. And to those watching on YouTube, we had to resume the recording for this poetry delivered by Mark.
Well, maybe we can, in the last, I know we're a little bit over time, but I feel like Yuki has worked so hard on some of these teaching points. And Yuki, there's so much here, so please do not cover everything, but maybe if you want to highlight maybe 2 or 3 of the teaching points that really stood out to you. And thank you so much for doing this for the first time.
Okay, literally, oh, I just wrote this. Okay, I read it. Okay, so first, learning object develop a framework for hypertension. Map develop is necessary for developing a quick approach, and determining mechanism of hypertension can also help in deciding management. So, for example, dividing cardiogenic, hypergenic, obstructive, and distributive. And these causes not only tell us about the mechanism of cause, but also guide us for evaluation. And maps can help us decide what's actually causing hypertension. And next, rapid response. First, ask for help. There are a lot of laws in rapid response. And ask for first aid vitals, access to fluids, to IV lines, because they are really preferably for large bowlers and antibiotics. And vital signs is vital, and then pulse pressure is proportional to stroke volume and inversely proportional to SVR. And low pulse pressure in cardiogenic and high pulse pressure in distributive. An extreme case may be warm in septic shock related as a distributive shock, and the cardiogenic shock may reveal cool extremities. JVP may be elevated in cardiogenic shock, and passive regularized tests will show increase in pulse pressure in distributive shock like septic shock. Checking perfusion using mnemonics, rider pass. The B stands for brain, U stands for urine output, S stands for skin. And ROM skin means low SVL state. Capillary repair used as assessment of perfusion has multi-benefit. JVP may be elevated in cardiogenic shock, possible leg test of, okay, and POCUS is also important. It's really helpful to detect obstructive shock. So use of POCUS for volume stage assessment is getting controversial, but IVC collapsibility and the diameter of IVC is used to assess for volume stages. Next one is learning objective, develop a framework for sepsis. Sepsis is a dysregulatory response to infection leading to organ dysfunction. Search criteria are recommended over Quicksilver. Common causes, skin, lung infection, etc. Other causes of distributive shock, neurogenic, anaphylaxis, and capillary leak, like cytokine storm. Next one is learning objective, cardiogenic shock, low cardiac index and high PCWP markers of cardiogenic shock. It is a surrogate marker of left LVEDP, elevated JVP, and signs of anesthesia can also help in determining cardiogenic cause. EKG, troponin, focus findings such as V-line can all give important information. History is also important. And the last one is management of sepsis. Ordering septic bundle of labs quickly is important. 30 cc fluid per kilogram fluid within 3 hours of suspicion is really vital. Balanced crystallized should be used. Normal saline, it can cause acidosis. L is very patient specific. L is more physiological in terms of sodium, generally cover all, and in terms of antibiotics, generally cover all bacteria with broad spectrum antibiotics like vancomycin. And this patient has heart failure. So fluid in heart failure in general, small studies show patients who receive 30 cc per kilogram have better mortality. Only but the limitation is how much of pulmonary edema does patient have. So much.
So many teaching points. Thank you so much, Yuki, for summarizing all of that. I think so many teaching points. So thank you for going through all of that. I just want to thank everyone for tuning in for to this first intern bootcamp session. We're still figuring out kind of the best format, so really appreciate you joining, participating in the breakout room, sharing your thoughts, and as Yusuf said, definitely fill out the feedback form, and we'll plan another session in the future. So thank you all so much, and huge shout out to the teaching from Mark, Yusuf, and Sarah too. All right. Bye, guys. See you at the next VMR.